Good morning. Thank you very much for the opportunity to present on this great session of the European School of Urology. In my presentation, I will discuss renal tumor assessment in daily practice, focusing on how nephrometry, Bosniak classification, and emerging KI-RADS concepts can support surgical planning and functional preservation. My talk has several short parts. First, I will introduce the clinical role of nephrometry, then we will review the main scores and cases, discuss Bosniak classification, functional preservation, clinical workflow, KI-RADS, and finish with practical conclusions. According to the EAU guidelines, the partial nephrectomy is recommended as the treatment of choice for the T1 renal cell carcinoma because oncological outcomes are comparable to radical nephrectomy, while renal function is better preserved. EAU lists PEDOA, SPER, renal, C-index, ABC, DAP, and zonal nephro as objective anatomical classification system in RCC. At the same time, the EAU also lists MAP as the tool for assessment of adherent perinephric fat and predicting intraoperative and postoperative complications during partial nephrectomy. The nephrometric systems allow a standardized perioperative assessment, surgical decision support, perioperative risk prediction, patient counseling, outcome comparison across centers, objective prediction of potential morbidity of NSS, and tumor ablation techniques. Why the nephrometry actually matters in renal tumor strategy? The main message is simple. Size alone is not enough. Two renal tumors of the same diameter may have completely different surgical complexity depending on endophytic growth, sinus contact, and hilar proximity. Size alone does not capture the risk of collecting system entry, vascular reconstruction, ischemia time, or parenchymal loss. A high-quality radiology report should describe not only tumor size, but also exophytic or endophytic growth, sinus and collecting system contact of the tumor, polar location, hilar relation, and rim involvement. It should also mention exposure difficulty when perinephric fat is relevant. All in all, the nephrometry helps standardize communication for the surgical planning. Recent comparative evidence showed that nephrometry can predict relevant surgical outcomes. In the head-to-head study, SPER nephrometric system performed well with an area under the curve about 0.79 for surgical success and about 0.98 for completion of partial nephrectomy. Therefore, nephrometry should be viewed as the structural risk stratification tool. It's not only descriptive radiology add-on, the score should be interpreted together with the eGFR, chronic kidney disease, morbidity, surgeon experience, and institutional expertise. Let's stop on the major nephrometric systems and several cases. The renal nephrometric system was introduced by Kotikov and Uzo as a standardized system for the quantifying renal tumor size, location, and depth. The five components are radius, exophytic or endophytic properties of the tumor, nearness of the tumor to collecting system and sinus, anterior or posterior location of the tumor, and location relative to polar lines. The total numeric score usually stratifies lesion into low, intermediate, and high complexity. The H suffix is used for the hilar tumors, which are often technically more demanding. This system is intuitive and widely used, which makes it practical for tumor boards and communication between the radiological departments and urologists. The limitation of this system is that it does not directly estimate adherent perinephric fat or the exact amount of the parenchymal volume that will be lost. Let's stop on some cases. In case 1, 45-year-old woman with 3 cm clear cell renal cell carcinoma of the right kidney. The solid line shows the expected renal contour used to determine E, exophytic or endophytic attribute, and in this case the tumor projects more than 50% outside the renal cortex and should be assigned E scored of 1. The final renal score is 4A. In the next case, the 63-year-old man with a 1.8 clear cell renal cell carcinoma of the right kidney. We can see the solid line shows expected renal contour used to determine E, means exophytic or endophytic attribute of nephrometry score. And in this case, less than 50% of exophytic growth was observed, and the score of 2 was attributed. The final renal score was 5P. In both cases, the low surgical complexity was, according to the final renal score, was attributed to these lesions. In the next case, number 3, the 52-year-old man with a centrally located clear cell renal cell carcinoma with both X and H attributes was assessed according to the renal score, and the final renal score was 9XH. And in the case number 4, the 73-year-old man with a centrally located clear cell renal cell carcinoma of the left kidney. In this case, X denote the central location of the tumor. The E score was 3. It means that the lesion was entirely endophytic, and the final renal score was 11X. In both cases, there was a high surgical complexity according to the final renal score. The next system is PEDUA. It was developed by the Ficara and co-authors and was developed to predict perioperative complications in patients undergoing nephron sparing surgery. It includes tumor size, exophytic rate, polar location, renal rim, renal sinus involvement by the tumor, and collecting system involvement. A key strength of this system is detailed assessment of the renal sinus and collecting system relationship, which are clinically important during the resection of the endorenopathy. The original work showed that PEDUA can stratify patients into different complication risk subgroups before the surgery, and compared to the renal nephrometric system, this system provides a more detailed anatomical description, although it may be less convenient for the rapid routine reporting. Let's stop on some cases. Case number 5. On this image, on the CT image, we can see the 6-centimeter tumor of the right renal mass. The less than 50% of the exophytic growth, median rim location, renal sinus involvement, collecting system involvement, and anterior face location. According to the PEDUA, the final score was 12. And case number 6, the CT contrast enhanced CT image demonstrate a heterogeneously enhancement 4-centimeter tumor of the left lower pole of the kidney, of the left kidney, which cross the polar lines, abuts the renal sinus and the lower pole calyx. According to the renal score, the final score was 9, and according to the PEDUA, the final score was 12, which is, according to the renal score, is intermediate surgical complexity, and according to the PEDUA system, it's a high risk surgical complexity. This case showed that in real practice, the same renal mass may receive different complexity categories according to the different scales. And I have the question to the panel. In cases of discordance between the nephrometry scores, when one of system classifier renal mass has high complexity while another suggests intermediate complexity, how would you approach surgical decision making? Would you manage the case according to the highest risk score, assuming the greater surgical complexity, or would you rely more on overall clinical and anatomical impression, treating as an intermediate complexity lesion? In a multi-center RARP cohort of 277 patients. Both Padua and renal systems correlated with the post-operative outcomes. Padua showed area under the curve about the 0.61 for predicting warm ischemia, about 20 minutes, and about 0.64 for high-grade Clavian complications, and the renal system was similar but slightly lower. Nephrometry also can correlate with oncological outcomes. The renal had a hazard ratio about 1.43 for recurrence, and Padua the hazard ratio about 1.80. The maximal tumor diameter was the strongest predictor for every 1 centimeter increase in diameter. The estimated rate of recurrence risk correlated increased almost by 200%. The next system is SPER. The SPER is a simplified Padua-derived score. It may be useful because it's easier and faster to apply while still preserving predictive value. However, it's less historically established than renal or Padua, so its adoption depends on the local team familiarity. This system focuses on the 4 practical parameters: rim location, renal sinus involvement, exophytic rate, and tumor dimension. This makes it attractive for routine use because it keeps the most clinically relevant features and reduces the report complexity. C-index, DAP, and ABC, and also zonal nephro scores are less common but conceptually useful and less often used in the clinical practice. The MAP is different from the tumor nephrectomy. Nephrometry predicts the adherent perinephric fat and exposure difficulty, not tumor complexity itself. In simple terms, tumor scores estimate resection complexity, while MAP estimates how difficult it may be to expose the kidney. And in this slide, we can see the principle of the MAP score assessment. On this actual CT scan, it's demonstrated the method of measurement of the perinephric fat at the level of the renal vein to determine the MAP score. The MAP scored from 0 to fine. Posterior perinephric fat thickness gives 0, 1, or 2 points, and fat stranding gives 0, 2, or 3 points. The higher MAP means higher probability of sticky fat and more difficult exposure during the partial nephrectomy. Let's talk about the updated Bosniak classification. The updated version of Bosniak classification estimates malignancy risk in cystic renal masses. The approximate risk is close to 0 for Bosniak 1 and below 1% for Bosniak 2 categories, and variable malignancy risk up to 38% for the Bosniak 2F category. Also, around 50% malignancy rate for the Bosniak 3 and around 90% for the Bosniak 4 categories. And also, we do not apply Bosniak classification to the infection, inflammation, vascular lesion, or necrotic solid tumor with a solid component more than 25%. Also, small renal masses may not be characterizable due to the partial voluming. Bosniak class 1 and 2 cysts without or with only fewer thin septa usually do not require the follow-up, and Bosniak 2F is the follow-up category. It's a cystic mass with many smooth enhancing septa on either CT or MRI examination. The key worrying sign in this class of the cyst is the morphological progression, especially progression to the Bosniak 3 or 4 categories. Bosniak 3 Cysts have the usually few irregular thickened up to 3 millimeters septa with obtuse margin which enhance after the contrast in the whole contrast administration, and the Bosniak 4 cystic mast have usually the significantly thickened irregular wall above the 4 millimeters and usually less than 25% of the lesion in comprise of solid tissue. The CT, you can see the example of the CT lesion, which is comprised less than 55% of the cystic changes, and in this case, the Bosniak criteria should not be applied. So, according to the EAU guidelines, the main clinical message in regards of the updated Bosniak classification is that in class Bosniak 2F cystic masses, we follow up to 5 years. Some of them are malignant. Bosniak 3 cyst, we apply surgery or active surveillance. Over the 50% of these lesions are malignant, and in case of Bosniak 4 lesions, usually we treat them by the surgery because most are malignant. Nephrometry is relevant to functional preservation because higher complexity tumors are usually more central, more endophytic, and closer to the sinus or collecting system, which may increase resection difficulty, ischemia time, reconstruction demands, and parenchymal loss. However, the score itself does not determine the renal function. The nephrometric score helps estimate the key functional driver, how much the healthy vascularized renal parenchyma can realistically be preserved. Therefore, the nephrometry should guide not only surgical difficulty assessment, but also preparative planning of a parenchyma sparing strategy together with the EGFR, kidney function status, MAP score, and patient-specific risks. On the slide, the proposed algorithm summarized the practical workflow using the nephrometric scores. First, we should characterize the mass on the multiphase CT on MRI, then assess the main nephrometric score, and also we may use MAP classification if needed, then assess the renal risk, estimate the partial nephrectomy feasibility, and document the multidisciplinary team decision using the anatomy plus renal function. So the key message is that the management of renal lesions should combine imaging phenotype, nephrometry, exposure difficulty, and the baseline renal functional reserve. Now let's talk briefly about the future direction. The KI-RADS, it's a developing framework, not currently validated and not currently actually presented for the clinical purposes. It's currently in development, and its future role may be broader than the standard nephrometric scores. It going to combine surgical complexity, cancer likelihood, and biological aggressiveness into one structured imaging-based approach. And its potential value is integration of Bosniak type cystic assessment, solid renal mass characterization, imaging biomarkers, and clinical decision pathway. And similar to the KI-RADS criteria which we use for the prostate cancer, this classification is based on the multiparametric MRI. Furthermore, this classification not only provides a standardized score on the severity of renal suspicion lesions, but offers a simple surgical score that communicates to urologists the preparative planning in the rapid manner. And this system could inform the need for treatment or active surveillance and reduce prevalent overdiagnosis and overtreatment, and also may help avoid, for example, for unnecessary biopsies of the kidney lesions. To illustrate the potential value of the KI-RADS, we can refer to the clear cell likelihood score, an imaging-based structure system that is designed to estimate the probability of clear cell RCC, and which is currently used in clinical practice. And this concept shows how imaging may move beyond the morphology alone and help to predict histologic subtype and potentially more biological aggressive renal tumors. It uses 5-point Likert score, from 1 meaning very unlikely clear cell renal carcinoma to 5 meaning very likely, and it applies a solid renal masses without the to solid renal masses without the microscopic fat. The future direction include also three-dimensional nephrometry. In one recent study, the nephrometry scores calculated via three-dimensional models of the Padua, renal, CSA, and ABC scores predict complications after the robotic assisted partial nephrectomy with higher accuracy than conventional two-dimensional imaging. In another study, the use of three-dimensional models gives lower complexity scores for kidney tumors in comparison to standard two-dimensional scans. Thus, the three-dimensional nephrometry may shift nephrometry from the static score calculation towards more individualized surgical planning and risk prediction. The final take-home messages. The nephrometry is a structured translation of the CT or MRI anatomy into the surgical risk language in renal cell carcinoma. The European Association of Urology recognized the renal, Padua, Spersi Index, ABC, DAP, zonal nephro, and MAP as useful anatomic or morphologic systems. Recent comparative evidence suggests the strongest oriented the curve values for the SPEAR system. The latest Bosniak classification used for cystic renal lesions to guide treatment tactics. The MAP should be added when exposure difficulty from the adherent perinephric fat is relevant. KI-RADS system is a concept intended to integrate surgical complexity, probability and malignancy, and biological aggressiveness into unified structure imaging-based network framework and still in development. The nephrometric scores guide surgery, patient counseling, and MDT communication, but final decisions must integrate patient factors and surgical expertise. Thank you very much for the attention.